You're watching CVN, continuing coverage of ESC Congress 2011.
Welcome back. I'm Tony DeMaria here with Spencer King at the European Society of Cardiology meeting, reviewing the highlights of the late-breaking clinical trials. And one of the interesting studies, one that I might not have thought of doing myself, was the CRISP-AMI trial, a trial of whether or not routine application of intra-aortic balloon counterpulsation would be effective in patients with large acute anterior myocardial infarctions.
Yeah, the investigators picked patients they thought had big infarctions, so they were limited to anterior infarctions, and they implanted a balloon pump in one group and not in the other group. And the outcome was measured as MR assessment and several days later of the infarct size to see if balloon pumping could reduce infarct size, and it did not reduce infarct size at all in this group. There are a couple of caveats about it, though. Some of the patients without the balloon pump did deteriorate, and they did badly, and so they got balloon pump. But so it raises the question of, yes, you don't routinely use a balloon pump for an infarct with stable hemodynamics, but if the patient starts going badly, maybe a support of some kind, balloon pump or the more effective means that we have now, should be employed.
Sure. Now, they did have a secondary endpoint, which was a composite of multiple events, and they were able to show a very marginal, statistically significant benefit. But I think the overall message, as you say, was that the routine application of intra-aortic balloon pumping following a successful PCI in acute MI really doesn't help very much. And I guess it raises the question of, after all of these years, we do very well at opening up the infarct artery, but in terms of reducing infarct size after that, dealing with no reflow and whatnot, we really haven't come up with a great strategy, have we?
Yeah, this one was infarct. They put the balloon pump in before they opened the artery in this case.
Right.
But still it didn't work in terms of reducing infarct size. But this does not mean that we ought to give up trying to reduce infarct size, because there are a lot of ways to work to the no reflow, the microcirculation. There are a number of other ways, but it probably makes sense because these are stable hemodynamics, and we put the balloon pump and we changed the hemodynamics a little bit, but not much, and so it didn't really do anything.
Right. Now, one of the other interesting, to me, perhaps the study that will affect my practice the most was the PRODIGY trial. And the PRODIGY trial asked the question as to whether dual antiplatelet agents therapy, which at this point in time is aspirin and clopidogrel, should be continued over an extended period of time after the application of a drug-eluting stent, or in fact a bare metal stent. And so the protocol here in PRODIGY was randomized prospective, allocating some patients to 6 months of dual antiplatelet therapy and other patients to 24 months of dual antiplatelet therapy to test whether that prolonged antiplatelet therapy would be of benefit in reducing late complications, particularly stent thrombosis. And surprisingly, the answer was no, that in fact there really was no difference. The slides they showed, the two data lines really were almost superimposed on one another.
Yeah, as we talked about earlier, the late stent thrombosis is better with the latest versions of stents. And our guidelines all say that you should, with drug-eluting stents, use 1 year of double antiplatelet therapy. But that's coming into question. This trial looks at 6 months versus 2 years. Other trials are looking at as short as 3 months for some stents. So I think the question is not yet answered, but this one contributes significantly to the raising the question, should we consider changing our recommendations?
Yeah, it's been my practice, actually, to keep patients on for even a little bit longer than 2 years if they tolerated the therapy, and I think I may well change doing that. Of course, they did continue aspirin therapy, and that's got to be taken into consideration.
Yeah, and the thing we have to remember is the antiplatelet therapy. It's designed for the stent, but it's also designed for the whole, circulation, the whole coronary circulation. And so we may be preventing events that are not related to the stents with longer duration, but is related to the stent. It's a question. Maybe it's not really necessary to use quite as long as we had thought before.
Yeah, and it's also intriguing, and more or less as a wrap-up, to think of the very positive results that we saw early in the meeting with apixaban and rivaroxaban, and that perhaps these agents in combination with aspirin and or thienopyridine might be a bit more effective as we go in the future.
Yeah, we're struggling on the margins, though, because we've cut the thrombosis pretty low, and so the ability to add to that is becoming more and more difficult, and everything we add is going to cause more bleeding.
Right. Well, generally good news, a very fascinating meeting. It's been a pleasure to have the opportunity to review these trials. For CVN, I'm Tony DeMaria.